Hello and welcome to the newest edition of Pharma Talks. Today we're going to be talking about universal healthcare and how other countries have approached universal healthcare. But before we get into that, I'd like to remind you to rate, review, and subscribe. Hello and welcome to the newest edition of Pharma Talks. My name is Alex Hernandez. Alongside me as always is Dr. Craig Stern. And our topic for today is how do countries approach universal healthcare? There's been a lot of talks in the news. I'm sure you heard it from the Democratic side about Medicare for all, which is kind of a take on universal health care, but it's a little different, and we'll go into some of that in a little bit. But first, let's talk about how universal health care is approached. So, Dr. Stern, would you help us with that?
Yeah, the argument has been made that the United States is the only major developed country that does not have universal health care. And so the argument has been that 7 presidents tried to get some sort of universal health care. Obama finally got something with regard to the Affordable Care Act, and then there's been a whole political fight back and forth, fundamentally based on the question of, is healthcare a privilege or a right? Now, taking that totally separate, because in other countries it is considered a right, not a privilege, versus the United States where it's a privilege, the question that we want to bring up here is not a political one, but rather, if people are talking about healthcare, how do other countries do it? What is this that they're talking about, so that we've got some idea, not just what politicians talk about, but what countries are actually doing.
Right, and thanks to social media, we now know most of Europe has either a socialist economy, which has been proven wrong, but also talked about universal healthcare and how people in those countries, citizens of those countries, have healthcare at birth. When they're born and they're a citizen of that country and they already have health care. Yes. So how is that approached in different parts of Europe?
Sure. There's effectively 3 broad categories of universal health care.
Okay.
In fact, the Commonwealth Fund did a study of 19 countries, took a look at this and came up with it. I wrote about it in one of our pharmacy benefit news blogs, and I think that Emma's going to attach it to this so that people can read it should they choose.
She is, because she's our producer extraordinaire, and she'll have it up there in an orderly fashion. Right, Em? Thanks, Em.
But effectively, there's 3 main models. One is a private entity, one is a public entity, and the third is a mixed entity. There's a fourth that has been approached in some recent studies, and that is from Australia, where they're talking about a lump sum that is given and then everybody has to pay off that lump sum, which kind of sounds like a savings account that we've talked about in the United States. But I'll leave that to the side for the moment, and I think we should talk about what does it mean to have a public insurance, what does it mean to have a private insurance, and what does it mean to have a mixed?
Well, go ahead and give us some examples of a public insurance. What country is giving the public insurance?
Okay. The public insurance option looks like the following. There's a single payer model, which is the federal government.
And we've heard that a lot. In Congress, they talk about single payer system.
They do. Yeah. And it's funded by tax revenues.
Okay.
And effectively, everyone is covered. They have coverage that includes mental health, dental, and eye care. And interestingly, there are no copays. So in that regard, the federal government covers everybody in a public health. It leaves open, however, the ability for individuals or companies to buy additional healthcare insurance, which allows them to get healthcare faster and potentially to deal with surgeries faster and getting to see specialists faster. So there's generally a tax system that deals with the public health insurance, deals across the board for everybody, includes mental, dental, and eye care, and at the same time also has no copays and ability, if you want to buy more insurance so that you can get to people faster.
Okay, so with the public insurance, you have pros like you're covered first and foremost. No copays, which I actually like. That's really nice.
You like that?
It's really nice.
Okay.
But some of the cons seem to be longer wait times. Right?
Yes, absolutely. You see that in Canada. The main paradigm for the public health system is Great Britain, the United Kingdom, with their National Health Service. And without doubt, whether it's true in England or whether it's true in Canada, etc.,
Right.
there are potentially long wait times. Now, if you have a acute problem, someone has a heart attack, someone has acute surgical problem, appendicitis or something, then clearly someone can get in to see the hospital or otherwise. But in general, yes, there are longer wait times and fees that politically people would talk about here in the United States as the government paying versus individuals paying is an issue.
How does this affect doctors?
Well, the federal government pays contracts and pays doctors.
Okay.
So in effect, the doctors are employees of the federal government of the
That's
healthcare
right.
system.
Right.
So there's not doctors are not individual entrepreneurs going out trying to deal with particular specialties or particular niche kind of markets. They are all employees and they operate under the National Health Service in the United Kingdom.
So as far as for a doctor's benefit, it doesn't seem like that attractive of a profession when you're coming out of college.
I mean, it's a profession. It's well paying in comparison to others, but it certainly isn't the gravy train.
Right.
And at the same time, depending on the area, there may be issues about that there's a limit on how many specialists there can be in a given area. So, for example, if you specialize in a given surgical specialty, there may or may not be a capability for you to live where you want to live.
Right.
Because there may not be a need for that particular specialty. And furthermore, it happens, I know it happens in Canada, it certainly happens in England to a degree, and that is that the hospital and surgical time frames are not the same as they are in the United States, where we may have it that goes 24 hours a day.
Right.
They have it in a set schedule, like, for example, 6 in the morning until 5 at night. Then there isn't an area for any kind of surgery that is other than acute surgery during that time period. So that means that you don't have the same time frame, and as a result of that, there's a backup and a waiting time that occurs because people can't get in to see some of these people if it's a surgical problem or a serious dental kind of surgical problem, that kind of thing.
Right. So because the doctor is effectively an employee instead of, kind of he can self-contract or set his own schedule. He can't do that when he's an employee of the state.
That's correct.
All right. So moving on, let's go to the private insurance. What are some examples of these private insurance other than the obvious?
Well, dealing with private insurance, private insurance is where government sets the healthcare policy and it regulates the insurance industry.
Okay.
However, the delivery of healthcare happens individually at the health insurance basis. So while the government says this is what essential healthcare benefits have to look like, these are the regulations under how you can operate, this is what are the specific requirements financially for health insurance company to operate. In the private insurance, the government has established that, but they do nothing with regard to implementing that. All of that goes from the delivery of care to the private insurer. Now, there are subsidies. Low-income people get a subsidy to cover their cost of care. The supplementary insurance can be purchased for things like dental and glasses, but they pay separately than what the government has established as the regulations. There is a deductible, but they remove that deductible from primary care, from maternity care, children care, and home nursing care. So in a very general way, the private insurance market looks something like the Affordable Care Act, also known as
That's what I was
Obamacare.
getting to. That's what
So
it
it
sounds like.
looks something like
Yeah.
that when you see what's going on. And the paradigm for this is the Netherlands.
Right. So Netherlands have something similar to what the ACA looks like?
Yeah, something like that.
Something like it. Okay.
Yeah.
And what kind of regulations are put into place for, say, this private insurance model? Like you mentioned that there are some regulation. What kind of regulations?
Well, there are regulations that, frankly, are not unknown within the United States, and that is there's identification and definitions of what an essential healthcare benefit looks like, identifying whether doctor is included, which it is, hospital included, which it is, emergency room, which it is, issues with regard to laboratory, drug, and otherwise that are all part of that. So they set and establish definitions for that. They also establish requirements on financing so that an insurance company has enough financial wherewithal that if they receive premiums at the beginning of the year, that money is still available through the end of the year so that people can continue to get health care. So they have financial requirements, benefit requirements, definitions of what has to happen. But once again, they're effectively establishing the regulations, but they're hands off when it comes time in order to implement the care.
But it makes sense. I mean, you think about it, the private insurance model, we have it here in the United States, but where people seem to want to get away from it is, and it's more than just political leanings, it's more they are forced to have medical insurance. It seems like nobody in the United States wants to be forced to have anything.
Well, that's true. In the private insurance, like in the Netherlands, it is mandated that everybody must have insurance.
Right.
So once again, it's this issue about, is healthcare a privilege or is healthcare a right?
Right.
As we saw in the first public insurance, everyone has to have insurance because they're given it by virtue of the fact that they're a citizen of the government or a citizen of the country. In private insurance, everyone still has to have insurance for that and to deal with those issues. Both of these are operating under healthcare as a right, and everyone needs to have healthcare.
Right. So let's move on here. We've covered private, we've covered public. What happens when they're mixed? You mentioned the mixed insurance.
Yeah, the third major kind of role, and there are obviously people that have variations of all of this. In Germany, there are different kind of healthcare benefits depending on the province or what we would call the state that people are in within the country. But in a very broad way, there's the mixed model. And the mixed model has that government taxes support public and private insurance. So there's both a public insurance market and a private insurance market. And in that regard, everyone has health care insurance, and it's covered under government tax revenues that deal with that. And the government manages the funds, so they collect the money, they manage the funds, and they negotiate with the providers. So effectively, the government is the one that negotiates with doctors, they negotiate with hospitals, etc., in order to provide care. So there is a government provision, but the government in this case, separate from private insurance, actually gets involved in the process to a degree by identifying and negotiating with doctors and hospitals for that. Services do include comprehensive care, prescription medicines, and diagnostic testing. There is some cost sharing that goes on for doctor visits.
What does that mean exactly?
Well, in the United States, the discussion has been around moving from volume to value, where you want to make sure that the right things are being done, not just that a doctor sees 20 patients a day, for example, but that people are controlled with their diabetes, they're controlled with their high blood pressure, they're controlled with their thyroid condition, cholesterol, whatever. In this case, it's a similar kind of issue, and that is there is some general cost sharing that is available. Some of it is purely financial, and some of it is based on outcomes. So in the mixed model, there is some ability for doctors to demonstrate a benefit and outcome. There is cost sharing not just for doctor visits, but also for inpatient stays, dental and vision. So there is some cost sharing, and in that regard, aside from what I've just said, there's also cost sharing where people can pay a part of it, and the government pays a part of it in order to get certain levels of care, perhaps, that they don't get at a lower level. And finally, there are subsidies for low-income people, chronic diseases, disabilities, care for pregnant women and children. So there are some subsidies to help people that have common conditions that need to be treated.
Right. So you mentioned you went through the list. You correctly identified areas where there are differences between public, private, and then even the mixed model. But what I'm trying to get at is how do we make this? How do we as citizens of this country decide on what model is best for the country?
Well, it's a good question, and because everyone has a different model. As I indicated, in the public insurance model, the paradigm is the United Kingdom, Great Britain. In the private insurance, the paradigm is the Netherlands, and in the mixed model, the paradigm is France. Okay. So there's at least three general paradigms that you see across all given countries, with variations about what goes on, as I indicated, with Germany, with different kind of models of insurance in different, quote, states or provinces like we would think of it, and certainly some issues in Australia where there's a lump sum payment and they say this is it, this is the amount, and this is what can be used. Okay. The issue for us, the main argument has been, how do you pay for this? Right. The argument from those people who argue of Medicare for all or healthcare for all is that there would be some sort of a tax to it, and they've discussed issues of a additional 7% tax increase on individuals in order to address it. Whether that's enough, whether that's not enough is not the argument right now. The fundamental argument is, how do you choose? And it appears that, at least at the present time, the United States has moved closer to the private insurance model, where the government is kind of establishing standards, like the Affordable Care Act, where it established what the essential healthcare benefit looked like, and then left it to the individual insurance companies to develop it. So the Affordable Care Act and the rest of the government tried to move to this kind of model. Will that work or not? Clearly, there's an argument about choice and others, and there's some current arguments about allowing, as part of the Affordable Care Act, there could be an allowance for multiple states to group together and come up with a group kind of insurance, where you could sell insurance across state lines, which in the past has not been demonstrated to be a effective method. The data showed that it wasn't a good method, but maybe if you collectively put it together, there's a better way of doing it, lowering cost. And so people have looked at that as saying, okay, it looks like the Affordable Care Act. There are elements where we can expand it into what goes on. Clearly, selling insurance across state lines was more of a Republican issue. Democrats were against that. But there was always, even in the Affordable Care Act, there was this issue of being able to try some of these ideas in order to address it. And finally is this issue that, aside from whatever the tax issues are and collecting more taxes to pay for all of this, the question is, are there other ways to try and lower the cost? And one of the arguments has been that the cost on drugs in the United States is about 3 times what it is in the United Kingdom or in Great Britain. So the argument is
Right.
that, well, if the United States finds some ways in order to negotiate prices of drugs, that opens up more money in order to pay for this. Whether that happens or whether it doesn't happen, those are areas where people can kind of micromanage, nitpick, and come up with different ways in order to try and find a way to finance it.
And that's where our country's foundations get questioned, where they talk about free market and free speech and all this. Free market is being infringed upon because you got these drugs who were developed by, well, supposed to be developed by a manufacturer by itself. I mean, we've gone into talks about that, about how research and development is done by the government and then bought by manufacturers, private entities, and you can go to the previous episodes about that. But we've talked about that, and how do you tell a private company that we're going to regulate how much you can price something?
Well, that's a good question.
And we didn't talk about it earlier. Eli Lilly, after we've had the conversation about insulin, Eli Lilly has agreed to lower the prices of one of their insulins, right?
Right.
And then we still haven't heard from the other insulin manufacturers about whether or not they're going to drop their prices or not, but we'll let you know as soon as we hear about it.
And fundamentally, the problem continues to be what is the cost of a drug or a cost of a surgery, a cost of a service, versus whether it's affordable.
Right.
People could say, if there was something discretionary, I don't necessarily want that surgery because I can't afford it, or a particular service if it's discretionary. If it's life-threatening, then clearly that isn't something that you're going to discuss.
Right.
If it's a heart attack or if it's issues with regard to acute surgery, things like that. But having said that, the fundamental issue that people have to get to is, once again, this issue about privilege versus right. Exactly. And that becomes the question. Right now, there's arguments about, well, if you give people enough opening, if you give them enough options, then they can find something that's affordable. And the argument in the United States has been young people are forced to pay premiums that are more than what they would use, and so to give them some particular options. We always come back to the fundamental issue, and that is the law of large numbers. If sick people are the only ones to pay for insurance, then the cost of insurance rises in order to deal with the cost of all of these people. If healthcare is a feature for everyone, then healthy people, sick people, and people who are stabilized, their therapy is stabilized, everybody pays and everybody has to address it. Do we have a perfect model? None of these public, private, or mixed are perfect models.
Right.
And I think everybody is stretching, trying to deal with that, because fundamentally the underlying driver here is that the cost of care is getting greater. Right. The cost of the new genetic testing, laboratory testing, is rising. The test of new therapies, whether they're genetic test strategies for cancer or otherwise, are rising. We're taking diseases that are chronic diseases and or used to be mortal diseases like certain cancers, and now turning them into chronic diseases. All of that costs more. And then the new specialty medications that cost on the order of 100 times what standard therapies are,
right,
is also addressing. So underlying all of this is the fact that costs are rising. It's breaking that impact of cost versus affordability, and then this other argument. We're not arguing here for one or the other, but it is important that we don't just talk and say, well, government will pay for everything and everybody's going to address it. We really do need to understand the argument, and from a scientific standpoint, to look at it and say, what are other people doing? How are they handling it? And what are the pros and cons, so we can have a better idea. With one other statement, this is all of this is an experiment. Yes. Everybody has tried, or not everybody, people have tried public, they've tried private, they've tried mixed, and over time you see whether something is working or not, and you modify it.
Right. And you essentially keep the model with less cons than the other models.
That's what you keep trying to do.
Exactly. So in retrospect, you look at all these models and they all seem to make sense. You got public insurance, which is financed with tax revenues. You have private insurance where government sets a policy and regulates it. I mean, still some tax revenue is put into there, but essentially it's a private model. And then you have mixed where you have some public and some private, and you mix it together and see what works best.
That's right.
And it all seems to make sense, but it seems like the argument isn't the model so much as it is at least in the United States. It's not the model, it's what's being done to drive up these healthcare costs.
Well, fundamentally, you're right, Alex.
Yeah.
But let me kind of rephrase it.
Okay.
The fundamental issue here is there are several ways that we can approach healthcare. Clearly, people need and want more healthcare. Mm-hmm. And as the population increases, obesity increases, a lack of exercise, mobility increases, then even younger people have healthcare conditions that were not seen in the past.
Right.
The real issue I think that everybody has to say is whether you pick one model, which is more of a governmental kind of decision, do we decide to go with private or public or mixed or whatever? That's a government kind of decision.
Right.
On an individual decision, the thing that people are arguing about is who's going to pay for this. So in that regard, the argument that you're bringing up is, okay, are there ways to cut costs, use that money to pay for health care? Or are there other methods that there are besides tax revenues that will help cut the cost? Figuring the argument for Medicare for All, for example, is you put a 7% income tax addition on top of it in order to pay for this, and that takes a common kind of premium that employers pay. It's somewhere in the range of $7,800 a month, and this 7% covers about 2/3 of it. So
Right.
then the employer isn't paying as much, but with increased benefits, there's always the chance they won't raise salaries because they'll have to pay for more benefits. But
Right.
at least in their argument is that they're going to pay for 2/3 of it in order to do it. Whether that's right or whether that's wrong, that's for everybody to argue,
vote on and decide.
Decide. The larger question that we all have is how do we get health care in a way that people can afford it, with the understanding, and a major understanding here, that the cost of healthcare is rising, and it's rising all over the world. It's not just the United States. Clearly, there are opportunities in the United States that don't exist in other parts of the world because we pay more than do others.
Right.
But at the end of the day, the cost of new therapies, the cost of new diagnostics, the cost of people having to pay for healthcare providers, less healthcare providers, and the chance that more of this may be done telehealth or otherwise because of limits on how much people can do. All of this adds to the problem of if you do nothing, the cost of healthcare continues to rise, and it'll push you into something that you have to do.
Right.
If you choose, then you have to choose something and then balance off how you're going to deal with this, with the payment issue, how much young people will pay, how much older people will pay,
Yeah.
etc.
Yeah.
Complex subject.
It's a very complicated subject. And it's even hard for us if we get all the knowledge, we get all the information together, we put it all together. It's still hard to make a decision one way or the other, which one's better.
It is,
It's
and part
tough.
of this is, it's a policy decision. Government is going to have to come to some decision. The current political climate where people don't agree or don't compromise becomes a major problem because healthcare is looking for solutions, or at least a model that they can deploy, and then begin to argue that, well, you need to fix this, you need to fix that, and all of that. But if people can't even talk,
nobody can decide on anything, and meanwhile, all these private insurance firms are just waiting to see what is going to happen.
and the cost of
Keeps
healthcare
going up.
continues to rise.
Right. Well, that's all for today. Thank you very much, Dr. Stern. And I hope you at home got something out of this conversation. And I would like to also remind you, we are open to hearing any questions or comments that you may have at home. We'll answer them for you. And we'd like to also remind you to rate, review, and subscribe on whatever podcast platform you're using. And we will have a new topic for you next week. Have we decided? We haven't decided on one yet.
I don't think so.
No. Well, if you have any questions or comments, please feel free to leave one. If you have a suggestion for a topic, please feel free to leave one as well. And we will see you next week.